From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews. Thank you for joining us. I'm Dr. Neil Bressler, Editor-in-Chief of JAMA Ophthalmology. Today, we're going to look at a longitudinal cohort study evaluating retinal sensitivity and retinal perfusion in diabetic retinopathy. And joining me is the corresponding author of that report, Professor Noemi Lois. Professor Lois is at Queen's University in Belfast, Northern Ireland. Noemi, thank you so much for joining us.
Thank you. Thank you very much, Neil, for the opportunity.
Noemi, your group was investigating this association of retinal sensitivity with retinal capillary perfusion on fluorescein angiography. Before we get to why you were looking at that association, maybe you could help our listeners understand, how did you measure retinal sensitivity and where did you measure it? Was this just in the macula? Was it in the periphery? Was it the entire retina? So how did you measure it and where did you measure it?
We use a perimeter, so it's like doing visual fields, but the perimeter allows us to map the sensitivity values to what we see on the fluorescein angiography. So we can overlap the map of sensitivity to the fluorescein angiography to determine if, for instance, if we look at areas of ischemia, which we can see on the angiography, to determine what the values of sensitivity are at those sites, or if we determine sensitivity in an area that is well perfused, what the values at that site. So it allows the point-to-point relationships that we wanted to study. And we did that in the macula, in the mid-periphery, and in the further anterior retina. It's 110 degree, the field being tested.
I see. And so I understand the retinal sensitivity now. It's the values that you get similar to on a visual field, but you're comparing that with this retinal perfusion. So you can look at a fluorescein angiogram and maybe say, this area looks perfused, this area does not. Did you quantitate that, or was it just perfused, not perfused?
What we did is we certainly mark the areas on the angiogram, and then we had grids that allow us to determine point-to-point relationship. What we didn't do is to quantify the size of the area of ischemia, if that's what you meant, Neil. So is it a small area of ischemia versus a larger area of ischemia? What we show is that if the sensitivity map has a testing area that was inside an area of ischemia or outside in an area of normal retina, we will have a grid in which we will transpose that information. So we know this area has, say, 32 loss of sensitivity, which is an absolute scotoma. And where is it located? Is it in an area of ischemia? Yes, no. Or where is it? So we could correlate that sensitivity specifically with what we see in the angiogram. And also, I must say, we were looking at the pseudocolor images too, so that to make sure that, for instance, an area that did not have perfusion did not correspond to an area of a hemorrhage, for instance.
So now let's go to my next question in understanding all about this investigation. Why did you want to look at this association of the retinal sensitivity and the perfusion status in that area?
Well, the first important thing, of course, is that we as ophthalmologists are used to look at the structure. In the UK, we work a lot with patient and public involvement groups. And these are people with disease, families, and so on, members of their families, and they help us to shape the research we do. And we learn a lot from them. Of course, for people with diabetic retinopathy, for instance, and that's the area of the study here, what they mind the most is, of course, how it works rather than how it looks. Because if the retina doesn't look good to us in our testing, but it functions well, they are going to be functioning fine. So that's what matters to them. So they always tell us and guide us on what we should measure. Also, I apply that to when I design clinical trials. But we were actually at this point designing a clinical trial for retinal ischemia in which we were planning to test some new treatment that we are developing in our labs at the Wellcome Wilson Institute. We needed to determine what were the outcomes that we wanted to measure. And of course, function had to be one. But to understand function in the context of a new treatment, I needed to understand function in the disease itself. And then I did a review, quite extensive review of the literature, just to find out that there was not a lot of information prospectively about what happens in areas of ischemia in diabetes, which actually it was surprising to me. There's a lot of cross-sectional studies, but very few longitudinal, and none looking at what happens in the peripheral retina. And obviously the mid-periphery is the area that we always believed that was predominantly affected by ischemia in diabetes. So very much we didn't know anything. So that's why we set up to do this study.
I always think about diabetic retinopathy and measuring the visual acuity. You're stating that perhaps there's loss of visual function, not necessarily related to the central visual acuity, but also in the mid-periphery or in the periphery. And that's what you're measuring in part as well. Is that right?
Correct, yes. And it can affect the driving ability. So that is very important.
And do these patients come in complaining of function not working off to the side, or is this something hard to recognize? For example, patients with glaucoma sometimes do not recognize that they have substantial visual field loss. Is that something you thought might be reflected before you did this investigation?
Yeah, that's a very good question. I think some patients do complain of problems seeing at night, which might already indicate that the rod function in the periphery might be altered.
And you mentioned that there wasn't a lot done with this. What do we know from cross-sectional studies even before you did this? I know that the DRCR network, for example, looked at people with very severe disease, let's say proliferative diabetic retinopathy, and at baseline they saw that many of them had substantial visual field loss. Did you look at a spectrum of people or just at one end, this proliferative retinopathy, or did you look at people with severe non-proliferative, with moderate non-proliferative retinopathy? Who are the cohort you had planned to look at?
So we looked at people with moderate, severe, and a proportion had also PDR, proliferative diabetic retinopathy.
And so I understand now that you're going to look at these people at baseline and measure their retinal sensitivity and match it up to the perfusion status that you might see on fluorescein angiography. You mentioned that you then followed them longitudinally. How long did you follow them? And did you repeat those same studies? That is, you measured this retinal sensitivity and the fluorescein angiography perfusion at follow-up?
Indeed, we did. We had a cohort of 44 participants at baseline, 27 of whom had the repeated angiogram and the repeated perimetry at 1 year and 10 at 2 years. And we did look exactly at the same location.
What did you see at baseline? Did they have any loss in some of them for their retinal sensitivity and corresponding to areas of non-perfusion at baseline?
Yes, when we look at baseline, and you mentioned other studies before, we saw that there was a very strong correlation with the loss of sensitivity based on the perfusion status. So the areas of non-perfusion had marked reduction in sensitivity compared to perfused areas.
How about the other possibility? Were there areas of perfusion where they also had loss of sensitivity?
So we have areas that were perfused, that had an absolute scotoma, and there were areas that were non-perfused that had normal sensitivity.
Let's think about all these. I'm going to start with the group that had reduced perfusion at baseline. What happened with the sensitivity deficit in those areas of reduced perfusion over time?
So in areas that had loss of perfusion at baseline, there was a loss of sensitivity deficit. So the sensitivity deficit declined over time, indicated that the retinal sensitivity improved slightly.
Interesting. So you saw a decline in the sensitivity deficit over time in those areas of non-perfusion. Is that right?
Yes, correct.
How about those areas that were perfused at baseline? What happened to the sensitivity and the sensitivity deficit over time in those areas of good perfusion?
So similarly, the sensitivity deficit declined over time, but not as much as in the areas that were non-perfused at baseline.
Now, how about any areas that looked perfused, but you saw decreased sensitivity? Did those areas become non-perfused over time?
That's a great question because we wanted to look into that, but there was very little change in perfusion status. There were some very few that changed from perfused to non-perfused, but we couldn't see differences, but there were very few. So I don't think that we can draw conclusions.
And finally, did any of these eyes get anti-VEGF treatment between the time they entered at baseline and that 1 or 2 year measurement? And if so, did that affect any of these sensitivity measurements?
No. So all these patients were naive to treatment, and I think that's one of the strengths of what we saw, because we can tell this is natural history of the disease. We didn't do any treatments on these patients, so these were naive to treatment, and the measures reflect what the disease causes in these eyes.
Now, you mentioned that this was really under 50 patients that you really looked at. Can we generalize to the hundreds of thousands of people that have diabetic retinopathy, or is this just the beginning and this needs to be expanded to larger cohorts?
I would not expand to everybody, but I think that the observations are useful, and I hope that other groups will be looking into this, firstly, to see if we can reproduce these results, which is always very important, but then to see how generalizable are, because that's, of course, very important.
And beyond seeing if this generalizes to other people with diabetic retinopathy, do you anticipate looking at people with even earlier stages, let's say mild non-proliferative diabetic retinopathy?
I'm more interested in people that have higher stages of disease. And the reason is because everyone nearly with diabetes will end up with diabetic retinopathy. But very few end up with complications. Of course, we see many patients because the disease is very common. But very few people, around 7% probably, will end up with proliferative diabetic retinopathy. So there's few people that will progress. So I'm interested in selecting groups that are more likely to progress so that then we learn from them to try to see if we can then avoid that happening. It's a long discussion probably, but the earlier that you treat, the more people you're going to need to treat. For many people, that will never run into trouble anyway.
How long would you ideally want to follow these people? 5 years, 10 years? Do you think you might see more changes going on?
Yeah, so again, if we pick up the group that have higher risk, people with higher stages of retinopathy, we might see and we might learn more with shorter term. Of course, ideally would be to see them at least for 5 years. That would be the ideal thing. But again, if you select people that are at higher risk, and unfortunately this cohort had high A1C hemoglobin, and they are at higher risk. But this is the cohort that we actually saw in Northern Ireland, because unfortunately the control of diabetes is not that fantastic in people throughout the country here.
And finally, do you think it would be worthwhile looking for medications that might reduce the magnitude of progression of this retinal sensitivity loss, or is that just a dream?
Well, that's exactly what we would want to do. And that's how this started, as I was mentioning before, trying to find out, is it reversible? And the interesting thing is that because we saw that there are some areas of non-perfusion with normal sensitivity, and in fact, we found out in about 30% of areas had non-perfusion, but the sensitivity was normal. That, I think, gives us a little glance of hope, because might indicate that at least in some areas of the retina, at least in some patients, even those patients that we study who had not very well controlled diabetes, sensitivity was still normal, suggesting that there's either maybe some mechanisms in the retina to prevent or damage and to maintain sensitivity. And it also gives an indication that maybe if we treat early enough, that might be reversible still.
Well, I thank you so much for sharing this new information to us. It certainly opens up many more questions. So, Professor Lois, thank you again for sharing the information with us.
Thank you very much. Thank you, Neil.
I'm Neil Bressler, and I've been speaking with Professor Noemi Lois on her study with her colleagues from Queen's University in Belfast, Northern Ireland, looking at retinal sensitivity and retinal perfusion and how they might be associated with each other in diabetic retinopathy in a longitudinal cohort followed for up to 2 years. You can find a link to this article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.